Good afternoon. My name is Muss, and I'm a member of the Hematology Oncology Division at UNC and have a major interest in cancer care, especially in older patients. And I appreciate Dr. Mayer and Dr. Nichols inviting me today to talk about predicting the toxicity of cancer therapy. There are several issues to consider when we want to predict treatment toxicity. The first are the goals of treatment, and that is it cure or palliation? And then we need to consider the tools we have to achieve these goals, whether it be surgery, radiation therapy, chemotherapy, for select cancers, endocrine therapy, or newer and getting much more widely involved in cancer treatment, immune therapy. Then we need to know the patient's goals, and they're not always ours, especially in older people where maintenance of function frequently is much more important than a few months of added survival for a complicated treatment. Cancer type and stage determines the treatment options and whether the cancer is curable or not. And then there are patient factors, which include social, medical, and more financial factors. And financial factors just don't have to be the cost of care, but logistics, getting to the clinic, etc., losing time from work. There are biologic factors that we really can't control for, but may be very important, such as the pharmacokinetics of the drugs and pharmacogenetics, how patients metabolize drugs, things that are becoming more important, but that we don't always integrate into our decisions. And then there are the risks of treatment and toxicity, which is what we need to predict, but also we need to know the benefits. Is the risk of the treatment versus the benefit? If it's short-term toxicity, most patients will recover. Adjuvant treatment for breast cancer can be a miserable experience, but patients eventually usually recover. But long-term side effects of treatment, such as fatigue, neuropathy, infertility, secondary cancers, they are harder to deal with. Now, when selecting cancer treatment for older patients, we like to consider four issues. One, for older patients, we'll do a brief geriatric assessment, but these geriatric assessments actually are really appropriate for patients of all ages because they determine issues such as social support, nutrition, other issues that are germane to patients of all ages. Estimating life expectancy, which isn't as important in younger patients, but is important in older patients, defining goals of treatment, and then finally calculating the benefits and toxicities of treatment. So I'm just going to show you a model here. It's called Predict UK, which can tell us how to predict the value of treatment in breast cancer. And so this is a patient who's in her 70s in good health. She has a hormone receptor positive tumor. And we can put this in to learn how beneficial the treatment is. So this is a very good model. And by putting this patient in the model, we can learn what her 10-year overall survival is. And if she had no cancer, she was in her 70s, and we filled in some other data that I won't show you in the interest of time, she would have a 63% probability of living at 10 years if she had no cancer. If she had surgery only and said, I don't want any other treatment, her survival would drop to about 40%. If she took endocrine therapy, tamoxifen, aromatase inhibitors, or other treatments, it would go up to 45%. And then giving second generation chemotherapy or third generation chemotherapy, in this case, because she had positive lymph nodes, etc., allows us to calculate the benefits of treatment. So there are tools out there, and not only for breast cancer, but there are similar tools for colorectal and other cancers. Now, we can also predict surgical risk. This is a surgical risk calculator that's available to everyone using the American College of Surgeons National Surgical Quality Improvement program. And what I did was I filled this in for a patient who had a simple mastectomy, mild systemic disease. By that I mean mild diabetes, high blood pressure, and I put in her weight, and then I calculated what her surgical risk would be. And you can get this and figure out serious complications. You see, this is extremely worked out. Now, none of these models in predicting risk are perfect, but they give you estimates which are frequently better than your guesses. So this is a lovely program available for patients of all ages. How about radiation? This is a study that I'm showing you data of using radiation following lumpectomy for women with breast cancer. And the Requite trials are a whole series of trials looking at the radiation side effects for different cancers. And what the developers of these trials are doing is they're developing models to predict radiation toxicity. And here, the model predicts the risk of skin toxicity using whole breast radiation. And you can see to develop their model, they collected data from large series of patients treated in different trials or databases, 2,000 patients. And then they found another group of patients treated in different series, and they use it to validate it. And there are similar studies that are ongoing in other cancers that I note. And you can see they could predict acute erythema, which is redness of the breast, and desquamation, a more serious symptom where the skin breaks down like a terrible sunburn that you probably got when you were a kid. And they could develop a model to actually predict this kind of accurately in patients. So by going in, you could predict in an individual patient based on factors such as body mass index, breast size, and hypofractionation, which means whether the radiation was given in a shorter amount of time, a long period of time, whether they got a boost, a little extra radiation to the lumpectomy site, smoking, one of the worst things humans could do. And then in this case, tamoxifen use was related to the erythema, but not to the skin breakdown. So we're developing a whole series of models that doctors, advanced practitioners, nurses can use to help you predict your side effects. Now, what about chemotherapy, my area? So this is a patient I took care of years ago. She allowed me to photograph her, and she said, if your time hasn't come yet, not even a doctor can kill you. Unfortunately, she was wrong, and I use this to show expected toxicity from chemotherapy as a lead-in, because we can really harm patients with chemotherapy. So in older patients, we have actually developed a cancer and aging research group calculator, which calculates the effects of chemotherapy toxicity, serious toxicity, grade 3 to 5 toxicity, mainly grade 3, 4, which is severe side effects, terrible nausea and vomiting, fatigue, diarrhea, etc. And it was developed from a trial of 750 patients. We participated at UNC. These were older patients, but the model is appropriate and really probably lends itself to younger patients as well. It was a great trial. There were no eligibility criteria. It's just you need to be 65 and older, have a solid tumor, and be treated with chemotherapy. There were all types of cancers, curable and incurable in this study. And we used a geriatric assessment to evaluate numerous variables in these older patients. So we knew about their social status, their functional status, nutrition, mental health, polypharmacy, and comorbidities. So pretty important. And actually, all these things should be assessed in every patient today, not just older people, every patient. They're very important, and they allow any physician or APP to provide better care. They use the univariate analysis to identify the key variables and then put them into a multivariate model. And they developed odds ratios in the model to make a little scoring system that was simple. And I will show you this model on simple scoring. And so when you have a patient, you could put here is a patient I actually put in that I made up. And you put in risk factors for the toxicity. So a lot of things you would get out of the patient's chart, right? You know the age, you know whether they had GI or GU cancer or other cancer. You know what kind of treatment you're planning to give, standard or reduced dose. Polychemotherapy is a term some of you may not be familiar with. It gives more than one chemotherapy drug or a single drug, hemoglobin, and creatinine clearance. These are all going to be in every chart. However, the other circle variables are frequently not in the chart. So one or more falls, hearing impairment, limited in walking, assistance required with medication, and decreased social activity. These all came out of the geriatric assessment and proved to be important in predicting toxicity in the model. And you can see the scoring system, and you can imagine with different patients how you could fill this in. And it doesn't take very long to do this. And then what happens is, in our patient, they had a 7-point score. Okay, they were greater than age 73. We gave them standard dose chemotherapy, and we gave them more than one drug. And here's what happened. So in total risk score for grade 3 to 5 toxicity in panel A, you can see that 50% of patients had grade 3 to 5 toxicity. You can see the nice steady increase based on scores. And on the right is performance status. So performance status has been like apple pie in oncology, how a patient functions. 100 means a patient who's like an Olympic athlete, and a patient who's less than 70 usually has some other illnesses in addition to their breast cancer, or in addition to their cancer, or they have other cancer-related symptoms. And you can see the performance status was about worthless here and didn't predict anything, whereas the risk score was very, very helpful. But there are problems. First of all, not all toxicity is the same. So a very low white blood cell count, most patients aren't going to be aware of it unless they get infected. As opposed to neuropathy, where we had moderate to severe neuropathy, even a mild neuropathy in someone who uses their hands a lot, or someone who's a little older and may stumble, can be a major problem. It doesn't distinguish short from long-term toxicities very easily. This is really chemotherapy related to treatment, but it doesn't tell us what's happening a year down the road. As we said, lower toxicities, lower grade toxicities can have a profound effect on your quality of life. The side effects of curative chemotherapy, which usually involve more drugs, may differ greatly from palliative treatment used for incurable types of malignancies. And ideally, we need specific calculators for specific diseases and specific treatments. So there is a wonderful series of calculators, the CRAS score for chemotherapy toxicity, that's available on the web, developed by our colleagues at Tampa. And every day I see more and more models coming for everything, predicting the number of nodes, predicting other issues related to cancer care, which is really very important to patients. So this is the age of models. We have artificial intelligence, machine learning, etc., and we're getting much better at this. I want to show you a new calculator. This is a CARG, Cancer and Aging Research Group toxicity calculator for adjuvant chemotherapy in early breast cancer. So this is specifically now using a similar model to what I showed you before, just for breast cancer. And this was 473 women. They're 65 and older, and they all received standard adjuvant chemotherapy regimens. It was meticulous data collection. And you can see in panel A, there's the grade 3 to 5 toxicity. But this scoring system also predicted risk of hospitalizations, dose reductions, dose delays, early treatment discontinuation, and also something relative dose intensity, because we've learned that if you don't give patients a certain threshold dose of treatment, and these are patients potentially curable or increased probability of cure with chemotherapy, we may be shortchanging them. So this is what's common. This is published, usable now on the web, and really helpful. Long-term toxicity is a little bit tougher to characterize, and I'm showing you data from older patients because there's actually been a lot of data on older people, and that's where we worry very frequently about chemotherapy toxicity. There's issues in younger patients. People like Deb and her colleagues over the years have looked at quality of life, but here's a group of 256 women. They all received chemotherapy for early breast cancer. And you could see at the end of treatment, 58% had no decline and 42% had declined. And then we looked about a year after chemotherapy again. And of those who didn't decline, most didn't decline, but some did, about 14% of patients, small group. And perhaps this was due to long-term side effects or other comorbid illnesses. But of the women who declined, almost half of them fully recovered. And these are older patients. It's important to know I would say there's not a lot of studies on this in younger patients with other cancers, and we need to do this. But about half of the people who declined did not recover. So that's important to know when talking with patients about treatment and is a long-term toxicity. So what's coming? One, more validated calculators. Secondly, data from clinical trials and large databases. Increased use of machine learning to build the models, and then disease site specific toxicity assessments for all the modalities we talked about. So I'd like to thank you for your attention. I'm sorry I didn't Zoom this in person. I'm seeing my grandchildren for the first time in months, and so I appreciate you bearing with me. Thank you so much.